Hi, my name is Hallie, and I'm a graduate student at the University of New England in the Master of Applied Nutrition program. And today I am presenting a research proposal on the effects of magnesium supplementation versus dietary intake on magnesium repletion and cardiometabolic risk factors in adults with subclinical deficiency. Cardiovascular disease is the leading cause of death and disability adjusted life years, or DALYs, in both the United States and worldwide. Cardiovascular disease is highly affected by lifestyle. In 2023, it was estimated that 79.6% of DALYs from cardiovascular disease were attributable to modifiable risk factors. Diet specifically is well documented to play a role in the pathogenesis of cardiovascular disease, and healthy dietary patterns are recommended for cardiovascular disease prevention. A sizable body of evidence now demonstrates that magnesium is one such dietary component that plays a critical role in the progression of cardiovascular disease. Magnesium is required for over 300 enzymatic reactions and is integral for endothelial function, glucose and lipid metabolism, and affects inflammation and oxidative stress. Many observational studies have found that magnesium intake is inversely associated with hypertension, hyperlipidemia, coronary artery disease, insulin resistance and type 2 diabetes, atrial fibrillation, strokes, and other major cardiovascular events. Additionally, interventional studies have found improvement in cardiometabolic risk factors and outcomes with magnesium supplementation. So here are the RDAs and EARs for magnesium, and you can see that the RDA for men is 400 to 420 milligrams a day depending on age, while for women it is 310 to 320 milligrams a day. And the EAR for men is 330 to 350 milligrams, and for women is 310 to 320 milligrams. Magnesium is found in the greatest abundance in unprocessed plant foods, so leafy green vegetables, nuts, seeds, whole grains, legumes, and dark chocolate are some of the best sources. Foods that are high in magnesium also may be high in other nutrients that have been independently found to be beneficial for cardiovascular disease prevention, including fiber, potassium, vitamins E and C, carotenoids, omega-3 fatty acids, and anthocyanins, just to name a few. As we'll talk about later, there is some inconsistency between the epidemiological studies versus the RCTs on supplementation, with more consistency in the epidemiological evidence and less in the interventional evidence, and this might be due to the phenomenon of food synergy. On the other hand, the Western diet has been found to be low in magnesium. Less than 50% of Americans meet the EAR for magnesium, and I'll just remind you that the EAR is the amount believed to be adequate for only 50% of the population. So subclinical magnesium deficiency may be common and contributing substantially to the cardiovascular disease burden. The literature on supplementation is less consistent than the epidemiological evidence showing a protective effect from magnesium on heart disease. Therefore, there is a gap in the literature regarding magnesium supplementation versus dietary magnesium and cardiometabolic risk. The proposed study seeks to answer the question, what are the comparative effects of dietary intervention versus supplementation on cardiometabolic risk factors and magnesium repletion in adults with subclinical magnesium deficiency? Our null hypothesis is that magnesium supplementation and dietary intake will not differ in their effects on magnesium repletion and cardiometabolic risk factors. Our alternative hypothesis is that magnesium supplementation and dietary intake will have different effects on magnesium repletion and cardiometabolic risk factors. Now we'll go to our research methods. So this will be an interventional study with 2 treatment groups in a parallel group design. Participants will be randomized in a 1-to-1 ratio using computer-generated block randomization, which will be stratified by sex to ensure even distribution of men and women. The primary outcomes measured will be HOMA-IR, blood pressure, blood lipids, and C-reactive protein, as well as serum magnesium and 24-hour urine magnesium. These were chosen because insulin resistance, hypertension, and hyperlipidemia are known to be causal drivers of cardiovascular disease, and chronic inflammation serves as a life-enhancing feature. And then we're collecting data on both the serum magnesium and the 24-hour urine magnesium because serum magnesium alone does not adequately capture true magnesium status. Most magnesium is bound in tissues. And so authors have proposed that using both urine and serum magnesium gives a better overall picture of magnesium depletion. The duration of the study will be 12 weeks. And in addition to the primary outcomes measure, the Diet History Questionnaire 3, or DHQ3, will also be given to participants at baseline and at the end of 12 weeks to assess for any dietary changes in each group, which we would expect to see in the dietary intervention group, and we will need to control for in the supplementation group. The two treatment groups will consist of a dietary intervention and that group will be asked to eat 2 servings of leafy green vegetables a day, 1 serving of nuts or seeds, 3 servings of whole grains, and 4 servings of legumes per week. They will also be provided with education on magnesium-rich foods and serving sizes. The supplementation group will be provided with 400 milligrams of magnesium citrate daily and given instructions for taking it. An a priori power analysis using G-Power was performed, and it was determined that we will need 90 participants. We plan to recruit 120 to 130 to account for attrition. Participants will be between the ages of 18 and 65. They will be screened for having serum magnesium of 0.75 to 0.849 millimoles per liter, which is how we are defining subclinical magnesium deficiency for this study. They will need to be able to provide informed consent, and they will be recruited at our local university, health clinics, pharmacies, hospitals, libraries, and community centers using flyers and social media. Exclusion criteria will be the current use of magnesium supplements, proton pump inhibitors, diuretics or magnesium-containing over-the-counter medications, a diagnosis of chronic kidney disease, cardiovascular disease, coronary artery disease, diabetes, or malabsorption disorders, a history of major cardiovascular events like stroke or myocardial infarction, or bowel resection, heavy alcohol use defined as more than 4 drinks per day for men and more than 3 drinks per day for women, and pregnancy. And these criteria will be assessed via initial screening. To ensure the privacy of participants and confidentiality of all protected health information, all data will be de-identified using unique study IDs. Data including daily compliance logs, food frequency questionnaires, and laboratory data will be maintained in secure electronic format. No photographs, audio, or video recordings will be made during the course of this study. The file linking the unique codes to any identifying information will be stored separately in a password-protected file, accessible only to the principal investigator and to study personnel who have completed the required human subjects and HIPAA training. All data will be stored in secure, password-protected files, and data sets will be analyzed using de-identified data only. After 7 years, the identifying information in the linkage file will be destroyed in accordance with institutional policy. And informed consent will be obtained from all participants prior to enrollment. Risks to participants. The most likely adverse effect for participants is GI distress from magnesium supplementation. And our research staff will monitor participants for GI symptoms and be available to answer questions, and will also adjust dosing as necessary. Bruising, pain, and lightheadedness can occur with blood draws. There is a very, very small risk of infection. There is the inconvenience of 2 24-hour urine collections. And then the dietary intervention group could also experience GI symptoms from dietary changes. And then finally, there is the time spent completing the training session, the DHQ, the blood draws, and the adherence logs. Statistical analysis. So descriptive statistics will be used to characterize the final sample of participants in terms of age, race and ethnicity, income, educational attainment, physical activity, and baseline measurements of magnesium and cardiometabolic markers. And then inferential statistics will be used to assess for differences between the treatment groups over time. A repeated measures ANOVA with a 2x2 design will be performed using the independent categorical variables of magnesium supplementation or dietary intervention, and the dependent continuous variables of serum magnesium, 24-hour magnesium, blood pressure, HOMA-IR, CRP, total cholesterol, HDLs, LDLs, and triglycerides. ANOVA is the ideal test for this study because it looks for the difference between two groups for a continuous dependent variable. And a repeated measures ANOVA will allow us to do a paired data analysis across 2 time points, baseline and 12 weeks. And this will allow us to answer our study question. So here's just a graphic of the 2x2 factorial design. You can see that we have baseline dietary 12 weeks, and then supplementation at baseline and supplementation at 12 weeks. Some of the possible outcomes of this proposed study are both groups could see equal improvement in repletion and cardiometabolic risk factors. And in this case, we do not reject our null hypothesis. 2, magnesium supplementation may lead to greater improvements in magnesium status. 3, dietary intervention may lead to greater improvements in cardiometabolic risk factors. And 4, effects may differ by outcome. For example, blood pressure may show a greater response to supplementation, while HDL cholesterol shows a greater response to dietary intervention. In conclusion, cardiovascular disease is the leading cause of death in dailies, and modifiable risk factors, including diet, contribute substantially to the development of cardiovascular disease. Magnesium is known to be integral to optimal cardiovascular health and disease prevention. Subclinical magnesium deficiency may be common and contributing to the prevalence of cardiovascular disease. It is unknown whether supplementation or dietary interventions differ in their effects on cardiometabolic risk factors and magnesium depletion. It is possible that supplementation is needed for repletion, but dietary interventions could lead to greater improvements in cardiovascular health due to the phenomenon of food synergy. The proposed study would fill a gap in the research and help shape clinical interventions and public health initiatives going forward. And here are my references. And thank you so much for watching.